Okay, good morning, everyone. I'm not a highly renowned international speaker, so I'm from just over the water there in Gateshead. And I was asked to just get the slides right. As it's just been said, my background really is mainly as a midwife, so my current role is head of safe care, which is really a strategic role around promoting high quality and safe care for our patients. So my background, again, is not an expert in respiratory medicine or COPD. And my involvement in this piece of work was really facilitatory in terms of my role around mortality. So if you've got any complex questions around COPD or some of the issues around there, I may not be able to answer some of those, but I believe we have got some experts in the audience who may well be able to. So, just to start off, and not to insult anyone's intelligence here, but I just did put a little bit of information in around the background of the work. And really it focused on chronic obstructive pulmonary disease, which you can see is an overarching term used to describe a number of conditions which are on the slide. COPD affects 3 million people in the UK, and it remains the 5th leading cause of death in the UK. And we know that more than 9% of over 45-year-olds in Gateshead will suffer from this condition, and 25% will actually die from it. There is a whole huge body of evidence and literature out there, one of them being guidance from NICE, the NICE clinical guideline, and also the publication of the NICE Quality Standard 10, which is around COPD. And we're really going to focus today in our workshop around Statement 11, which talks around how people admitted to hospital with an exacerbation of COPD who have a persistent acidotic ventilatory failure are promptly assessed for and receive non-invasive ventilation by appropriately trained staff in a dedicated area. And NICE defined prompt assessment and receipt of NIV should be defined as assessment and receipt of NIV within 3 hours of presentation and receipt of NIV within 1 hour of a decision being made to administer NIV. Non-invasive ventilation, for maybe people in the audience who aren't so familiar, it is a method of providing ventilatory support that doesn't require an AT tube, endotracheal tube, and usually delivered by a face mask. So as I've said, there is a large body of evidence out there, and actually that looks at ward-based non-invasive ventilation and the many positive outcomes that can have for patients. So reducing mortality, clearly having an impact on the need to to admit patients to critical care departments for NIV where it can't be supported outside. Improving survival of patients, we've talked about mortality. Cost effective in terms of reducing length of stay, but also in preventing admissions to the critical care department. So at Gateshead, we actually identified that we had a real need to improve the delivery and timing of NIV for patients with acute exacerbations of COPD. So this just tells you a little bit about how it came to light and what we've done about it and where we are to date. So this was the pathway for patients in Gateshead at the QE. Patients who were recognised as fulfilling the criteria in the emergency department, MAU, or out in the wards, if they met this criteria with respiratory acidosis secondary to an exacerbation which had persisted for 1 hour after full medical therapy, the process was that a bed would be requested to transfer the patient to Ward 4, which is our respiratory ward. This was often problematic. The patient would be transferred to the ward when a bed became available, often delays with a busy ward, high bed occupancy, and lots of specialist patients in that area. The other scenario was that no bed would be available because all of the machines that we had, which were 2, 3, were being used at that time. So when the patient did get transferred to the ward, then the NIV would be established, but often there were significant delays in initiating that. No beds available, then patients would then be transferred to the critical care department, and again, that wasn't ideal. So, drivers for change, what was happening? So this service, our NRV service, was set up in the early 2000s, and it really hadn't had no investment and had remained unchanged since then. At Gateshead, we were seeing roughly over 1,000 patients a year who were being admitted with acute exacerbation of COPD, with around 71 patients a year actually receiving non-invasive ventilation. We knew from national audit data that we should have been, or we would expect to treat 290 patients a year with NIV. So we really feel that, that there was we were missing patients. Up to 19 a month, and that was usually due to bed pressures, and sometimes the fact that the requirement for NIV wasn't actually recognised out there in the hospital. As I've said, it was limited to being delivered on the respiratory ward or in critical care. There was a provision for only 3 patients at any one time. We said that there were rarely beds available, and this was leading to suboptimal initial treatment and delay in commencement of NIV. And I think the other thing was that it relied on the staffing establishment on the respiratory ward. So there were, a very busy ward, and they already had 24 beds, which were occupied most of the time. So it was very demanding. I guess on top of that, we talk about, what outcome data do we have? Mortality from the national audit data for all NIV patients was around 40% in the 2012 audit, and that was compared to 31% nationally, so that was certainly of a concern. Readmissions were an issue. For example, in 1 month, I think this was September, one of the 4 patients who potentially could have benefited from NIV in 1 month was actually readmitted within 30 days of discharge. Length of stay, so patients going to critical care would have delays in transfer to the ward, and therefore their ongoing care, which had an ongoing impact on actually discharge home, so delayed discharge home. And we were failing to meet the target of NIV within an hour of failed maximum medical therapy. So the average was around 5 hours to commencement of NIV from A&E admissions, and 2.5 hours for patients who were admitted to critical care. So what did we do? I think a lot of this work progressed because of the work that we'd done in our organisation around reducing avoidable mortality. We'd spent a lot of time investing in really developing our governance processes for understanding mortality data, but also for actually developing really quality reviews of patients who died, and it all initiated actually on the respiratory ward. So this is going back a couple of years really, when Ward 4, the respiratory ward, started to develop multidisciplinary review of deaths, and it became a regular occurrence on a weekly basis. It became really, significant and meaningful. I think one of the key things initially was the different perceptions of the different professions within the team. Certainly, the views of how medical staff may have seen a patient's care or end-of-life care compared to how the nursing team saw it were often very much in contrast. And I think that really helped the ward team to see things from different perspectives and work together in that, in a more, I guess, cohesive way, understanding the way that the different ways of people coming from. So we had a process, and more recently we've introduced the Hogan and the NC-POD outcome scores to really look at how, which deaths were avoidable and how the quality of care could be improved. Once we had these processes in place within the ward areas, and it's been very slow and very incremental, particularly around trying to develop a culture of learning and organisational learning, We developed our governance framework in terms of setting up a mortality and morbidity steering group. And the process is that the wards come, or the services come to the steering group on a rolling programme and really present the cases and what we've learned from the review of deaths. And this is where we really saw a compelling case for the development of the NIV service. These were real people. It wasn't data. It wasn't numbers. You would follow the journey of a patient, and that would be presented in this meeting, and we could see where lives could have been saved. So the Mortality Morbidity Steering Group supported the service to develop a business case, which was successful. From that, we were able to fund 4 new NIV machines. We were to develop a nurse-led service, so that was 4.8 whole-time equivalent Band 6 specialist nurses to actually deliver this, and then some additional funding for training and education. And there were also some minor structural changes within the ward. The anticipated benefits, earlier involvement in patients with acute exacerbation across the whole trust, because the nurses are able to get out there and actually go and see patients. Leads to optimisation of treatment, preventing oxygen toxicity, and earlier access to arterial blood gases. Excuse me. Now, commencement of NIV in A&E and any ward area is available because of the portable NIV machines that we were able to purchase. So it's reduced the delay in actually patients starting the ventilation. And then prompted transfer to the ward because we have those beds available to transfer patients earlier. I guess it's also helped in identification of patients who may benefit from the critical care involvement. And the nurses are able to offer continued support and follow-up for patients who are already established on NIV. Their roles also around education and teaching staff across the whole trust. And we hope to see some results in terms of length of stay and the cost savings that may bring with it. But I think ultimately it's really about providing timely, safe and a streamlined pathway for patients. So our early results, so this service was really set up around December of last year, so very much in the initial stages. But we are very optimistic around the results so far. There is early evidence to show that it's working well for patients, and we are meeting the national standards. We're now seeing around 100 patients per month, with an average of 15 patients starting treatment on NIV, which is double that we previously were able to offer. And it's been achieved in 1 hour in 100% of patients in line with the BTS guidelines. Now, this data is limited to 2 months data, so as I say, it is very early results. The data also indicates that it's been successful in 76% of patients, an improvement on 66 in 2012. And we have seen some early indications in terms of improvement in mortality rates also. So I guess what were the key enablers? For me, it was very much about the whole ethos we have within the organisation around, very much patient-focused and our commitment to providing the best care we possibly can. And I think the fact that we have a fabulous safe care structure in the organisation where we have processes, and I think certainly the processes around how we learn from review of deaths and the actual clinical buy-in that was there, particularly, I think, from the medical director who chairs the Mortality and Morbidity Steering Group, but we also had the right people around the table. So it was a mixture of clinicians, a mixture of management, who actually worked together to really to develop that successful business case. I think there were some, I've just talked about some of the challenges, and you could see that obviously funding and staffing were key issues that we needed to overcome. There was some slight resistance, I think, from non-clinical people in terms of the setup costs and really what will we gain from investing in this service. But I think because we could demonstrate that actually people were dying unnecessarily, that was really, really powerful, and that really couldn't be argued with. So I think really this whole process around case review is much more powerful than just looking at data on its own. So for me, I think that really helped. So the future of the service, it is the beginning. We are looking at how we might expand that, growth of the team and the makeup of that team, and perhaps looking at the protected beds in NIV beds in the respiratory ward, and continuing really to educate and review. We've got a rolling programme of audit to constantly review where we are and what difference it's making and what we need to invest in to improve upon that. And I guess also, for the future of improvement is really to continue to develop and embed multidisciplinary reviews, and really ensure that key learning is communicated, and it's communicated to the right people at the right time, so that we can really make significant changes in the delivery of care. Another key challenge is also around actually having meaningful data, and for me it's about measuring what matters, because quite often it's quite a challenge to collect data. It often relies on clinical staff at the front line who don't always have the time to invest in that. So how do we as an organisation develop systems that are streamlined and easy to collect that information? We don't have an electronic clinical patient record, so often things are collected, collected through audit performers and relying on people to fill those in. And I think very much it's around encouraging collective efforts and recognising that we all work as a team if we are to affect sustainable change.
Good morning. It's nice to be back in the Northeast again. I'll try and follow that. That's a really nice example, so we'll see where we get to. If you remember, what I think we were trying to do last time was to say, in addition to all of the tools you currently have for improving quality, there's an emergent body of knowledge coming out of implementation science that might expand the toolkit that you have. And really what we're trying to do is sort of say, can we build upon what you're already doing to hopefully even further increase your effectiveness. And sometimes the things that we're saying will be highly relevant, sometimes they'll be less relevant. The example we've shown is that actually quite a lot of structural things need to be changed to actually get the changes in NIV. I'm going to talk for about the next 40 minutes or so and give you another model. I apologize, but this is a kind of just a basic model that will hopefully suggest a systematic way of thinking about this. This is a problem that we're trying to address. There's fairly consistent evidence globally that healthcare professionals and healthcare systems fail to deliver the quality of care that they'd like to their patients. Between 30 to 40% of patients don't get treatments we know of proven effectiveness, and around 20 to 25% of patients get care that's not needed or is harmful. And I think Averil's sort of example of the baseline data in Gateshead was just a really good example of, despite a trust trying to establish a system, it wasn't reaching all of the patients who could benefit from this. No healthcare healthcare system in the world has got this right. You can't go to the VA system in the US or Kaiser or the Australian healthcare system or China and find a healthcare system that solved this. And I think the fact that nowhere has got it right just highlights it's a really difficult problem. We're dealing with increasingly complex patients in increasingly time-pressured settings with increasingly sophisticated but often potentially also harmful treatment in what are kind of systems that haven't been set up necessarily to support quality. It often is a fairly kind of chaotic and time-pressured environment. And that's why we struggle. If we were living in a perfect world where we had lots of time to think about what we're doing with our patients, we had all the resources, all the staff to do that, we'd probably be fine. But our reality is not like that. And what we have to try and do in quality and implementation science is say, given what we dealt with, how can we do better? I put this slide up last time, so you all know what the ISGLIAT principle is. But this was a colleague, Martin Eccles, who is from Newcastle, now retired, but said often when you look at how people make decisions, they use the ISGLIAT principle, which is it seemed like a good idea at the time. So often you have a group of people who are sitting together, talking through a problem, and sometimes whoever's talking the last, or whoever's most senior, that's what will happen. And sometimes it works really well. Sometimes you get really good improvements in quality, which is great. But I think one of the questions that we'd like to pose is, if we start to use a more systematic approach, particularly starting to think about what we know about what the determinants of the behavior are and how we can overcome those, can we do better than this approach where it feels that people often go to a solution before they've thought about the problem? So that's what we're trying to do. And so implementation science is a relatively new area of health services research. I've been working in the field for about 25 years, but there's not many people who've been working longer than that. But basically, it's a study about how evidence moves into practice to improve quality of care and patient outcomes. And what we're trying to do is identify generalized principles that will help people on the ground just to further enhance what they're doing already. So we did have an initial masterclass in May, and I'm delighted that the newsletter said it was a success. As Jackie said, that was a kind of a broad overview, and we particularly focused on behavioral approaches. That's where kind of Justin and I have been working in. How does the knowledge from social and behavioral science enhance what we may be able to do? And we talked particularly about the theoretical domains framework and also the behavior change wheel. What we want to do now is use a case study and group work to think about using implementation science theory and tools to address clinical variation and raise standards of care. And then at the end of the day, to ask you to think about your organizational capacity at the moment with respect to skills, knowledge, resources required if you wanted to use some of this knowledge coming out. So my prior, and you can correct me by the end of the day, but some of the things we're talking about might require, for example, additional training or additional ways of reconfiguring some of the quality teams that you have if you want to bring them in. And we really just want you to kind of reflect on that. I'm going to use this model to guide today. So this is a knowledge traction cycle. You have a one-page handout. This was developed by a colleague in Canada called Ian Graham. But what Ian did was to look at 31 planned change frameworks from healthcare, from business, from other sectors, and do a critical analysis of them, and found that there were kind of common ideas that came through them. So he created the 30-second model. When I want to tease him, I say he created the 30-second model, but his argument would be this does bring together basically a very broad set of ideas. And I want to talk this through you, or talk this through with you just now. Is that last time we really focused on this area, and you can see actually there's a lot more that we need to do. And the idea behind this framework, it doesn't tell you what to do on a day-by-day level. It just proposes a systematic way of thinking through a problem. And the argument behind this is if you're a bit more systematic in how you do that, and in a staged way, you're more likely to be successful with your plans. And this isn't kind of rocket science. You could equally fit a PDSA cycle into this. You could fit other change models into this. And a lot of what Avril said, you could actually conceptualize using this. So it's not, I'm not trying to say this is sort of a brand new, and if anything, hopefully what you'll see is actually this is just you can recognize what you do already, and this is partly just a way of presenting this in a systematic way. So there's two areas of the knowledge to action cycle. The first is this knowledge creation funnel, and the second is the action cycle. I'm not going to spend very much time on, and there's the reference. So there's just a broader descriptive paper, but actually you've got the kind of key elements here. So the knowledge creation funnel, this is an inverted funnel, and it's got three sort of broad areas. The first is knowledge inquiry. These are the primary studies, the kind of trials that people do, or clinical studies. The next level is systematic reviews, and the next are knowledge tools and products like guidelines or patient decision aids or policy briefs. And the key idea here is that if you're interested in trying to improve quality or focus on improving care, you should really be focusing on these knowledge tools and products. We shouldn't, in general, be asking people to think about following the primary studies because they just can't keep up with them. And it's much better to have someone do that heavy lifting and then you to focus on, here's what a guideline says. And in the UK, you're very lucky. The NHS has invested hugely in doing systematic reviews and guidelines. So the Cochrane Library is available, but actually, Cochrane reviews are then incorporated into NICE clinical practice guidelines, and they become the standard of care. If you're in Canada, where I live, we don't have this. So there's not a kind of coherent national view about what we should be doing. And it means that we're starting probably 10 steps behind what you're doing. We'd probably have a greater argument about is NIV worthwhile or not, and what does it mean, than when you have a nice standard. So, the UK has invested a lot in this in the last 20 years, and it's a real credit to it, and globally would be seen as a world leader in terms of trying to provide guidance to the healthcare system. The counterbalance to that, Avril and I were talking about just the sort of deluge of information coming out from NICE, and basically how a healthcare system can also manage this information coming through. So I'm not going to really talk more about that, but largely to say, this is, there's a good sense in terms of avoiding a lot of work if you can start with NICE guidelines. So the outer action cycle just starts to talk about a systematic way to think about the problem and then to think about solutions. Couple of things. You can also, this knowledge creation, you can also find, for example, systematic reviews that might tell you about assessing barriers to care, or systematic reviews about how to improve quality of care. So, you can again sort of say, as we're trying to look at the knowledge behind these, largely, if possible, use systematic reviews or tools that have been made available and validated. The other thing is, although this looks as though it's a cycle and it's fairly linear, the reality of this is that you're often looping backwards. You try something, it doesn't quite work, you go back, you do something else. So again, this is a sort of oversimplistic model. The reality of this is that life is complicated and you're going to have to work it through. So, a traditional way when we talk about this, where you start is identifying the problem, and then identifying, reviewing, and selecting knowledge. So a problem could arise because you know that you've had a critical event within an A&E department, or you know at a population level that I forgot what the figure was, but there's a significant difference between how many patients you should be ventilating and how many you're actually doing. So you may have local data that says there's a problem here. Or there may be something like a NICE guideline that comes out and you think you're doing okay, but you actually want to check that. You want to sort of say, well, from the point of view of this guideline, are there areas that we need to try and address? I would argue that often if we're thinking about trying to improve quality of care, it's helpful to get people to think about the behaviors that they're trying to change. Sometimes we end up sort of really sort of making these quite abstract issues. We have poor rates of NIV in COPD patients, and starting to break it down into what are the behaviors we need to change. So Avril talked about people needing to recognize which patients had persistent acidosis and needed to have ventilation as the first point of starting the pathway. Now that would, if we separate it out, that starts to raise issues around, well, which clinicians are looking after these patients, what are their current levels of awareness, what are their work patterns, are there ways in which you can support them to recognise, Avril's smiling because she clearly went through all of this, but how do you support them to try and recognise that? There's then an issue, okay, once we've kind of recognised the at-risk patients, then there'd be an issue about how do you initiate NIV, and that might ask you, where are you going to do that? How are you going to do that? What are the staff involved? What are their learning needs involved? And so starting to break it down, I think it makes it much more manageable than a fairly abstract view. So here's a series of questions. What's the behaviour or series of linked behaviours you're trying to change? Who performs the behaviours? When and where does the potential adopter perform the behaviour? Are there obvious practical barriers performing the behaviour? Well, it sounds like when you started in Gateshead, this was only done in the respiratory wards, and there's an issue about getting patients into the respiratory wards. So there's an immediate problem if you're off the respiratory ward with acidosis and there just weren't beds. So very practical barriers that you can start to address. So this is just trying to be really concrete about what would look different in the organisation, what would people have to do differently if they're going to achieve what we'd like them to do. From a psychologist's perspective, they like us to be very specific and say sometimes it's really helpful to specify target behaviours in terms of the action being performed, the target at which the action is directed, the context in which the action is performed, or the timing during which the action is performed. But I think the issue is just having really trying to understand in the real world what is happening and what are the kind of issues around delivering care. Don't assume that you know what's going on, because you'll often find that there are interesting kinks in the system or ways we do it here, which you wouldn't have guessed if you hadn't said we really need to do a good understanding. So the next issue is about adapting knowledge to local context. You can think about this in two ways. I mean, some of the issues may be that you've identified a potential problem, but you need to do a deeper dive to understand where the problem actually sits. So it could be, it sounded like there was, for example, differential lengths of time of patients going in NIV if they're in A&E, or if they were in a ward and being transferred to critical care. So it may be very helpful for you to start to sort of do a deeper dive with your local data or to collect additional data to further understand what's going on. It could be that if you did a deeper dive, you found that people were recognising acidosis, they were maximising medical treatment, and then the block became immediately sort of after that in terms of we don't have the capacity to deal with these patients. And that would mean you could focus on that end. But if you found that actually there's a failure to recognise acidosis, or then there wasn't an attempt to optimise medical management, before you get to that stage, you might want to look at all of those. So often you may want to do a deeper critical view about what's happening in your organisation, wherever possible, using data to get a better sense of, is this a problem for us? Is it a problem across all the organisation? Are there particular areas of the organisation we should be trying to work in? How do we actually manage that? There then may be an issue about sort of just the guidance or the extent to whether the patients you have are very similar to, and the resources you've got are similar to the recommendations made, or whether you have to think about adapting the recommendation. So clearly across the northeast of England, and you have a very wide variation in terms of the resources available in hospitals, the academic expertise in hospitals, things like patient transport. There may be a whole range of reasons why the way you set up a system in Gateshead might be slightly different than if you were setting it up in Berwick or somewhere else, even more peripheral than that. So you may need to think about collecting additional data to assess the applicability of the knowledge to your local context, and then you may require modification of recommendation actions based upon applicability, resources, and context issues. These are kind of the area that Jess and I spend most of our time in, and the idea here is that if we're choosing interventions, we should try and understand what are the barriers to knowledge use, and then make sure our interventions try and address the major barriers that we've come across. So, sounds like a very straightforward idea, but quite often we jump to interventions without thinking about what it is we're trying to understand. I think we talked about this last time, but this is just a four-stage approach to trying to think this through in a systematic way, decide who needs to do what differently. That's that behavioral piece that we've got. Using a theoretical framework, which barriers and enablers need to be addressed, which intervention components could overcome the modifiable barriers and enhance enablers, how we measure behavior change. And what we've done is produce a worksheet where we've also added the sustainability piece. Because as Avril was talking, she was saying, well, it looks really good now, but actually we need to monitor this because there could be a whole range of reasons why this falls down in the future. If one of your FTEs goes off sick or changes, moves jobs, and you then have 3 months recruiting someone else, and there'll be a whole range of reasons why this could get derailed as you move forward. So again, this is not particularly sort of rocket science, but it's saying think about these, and if you start to map these out in a very systematic way, you may come up with exactly the same solution, or you may come up with a slightly more nuanced solution. So in terms of assessing barriers to knowledge use, this is really just following up what we talked about last time. I presented, so that you can do a number of things. You can do a formal assessment of the context or likely barriers of assessment by going out and interviewing or observing or collecting additional data. You could also, for example, do a literature review. There's increasing bodies of evidence out there that talk about what the barriers are. Which might help you to start to think about, well, actually, in the UK setting, we found 3 studies describing barriers to COPD care in hospital. What can we learn from those before we go out and collect more information ourselves? I presented this last time, and this is my own aid memoir. This was a kind of, this was an atheoretical view about what were the barriers in the world. And actually, if you look at what Avril presented, a number of these things fit into this, so that there was an issue about kind of skill mix and also role definition, who could actually do this. There's a lack of facilities or equipment. You didn't have enough schemes. Local standards of care, not in line with inside practice. It sounds like you had policies about where this could happen and they need to be addressed. And then you also talked a little bit about some of the knowledge, attitudes, or skills. And also this is just about the chaos of day-to-day life in clinical settings and trying to deal with these patients if you're not on the respiratory ward. So in many ways I find this serves me well, but it's kind of an idiosyncratic view. Avril would say things slightly differently. Justin would say things slightly differently. And so we may not communicate that well to each other, or we'd have to always describe what it is we meant as we use these. So this has led to potentially interest in basically using theoretical ideas or theoretical concepts which are based on real life observations. They're based on sort of looking at the world and then trying to make sense of them, but saying, can we start to develop comprehensive ways of representing the world that if we start to use the same language, we can talk together in a much more coherent way. So we talked about the theoretical domains framework last time. This was, if you remember, a synthesis of 128 ideas from 33 theories that said largely there are, how psychology says, there are 14 things that influence our behaviors. Within this, the theoretical domains framework, there's a qualitative interview schedule, which you can use in 30 to 45 minute interview and screen across where these major issues are. Okay? So this is, you could do that formally by interviewing people, you could do a focus group, or even in a quality team, you could start to say, well, let's actually think about this and use this as a framework, just so we don't forget about things. Because often when you sort of don't have a systematic way of going through things, you'll omit things that may be important. This is another model, the behavior change wheel. Both of the TDF and the behavior change wheel are both trying to do one of those things about just here's your way of thinking about the world. And people in our experience vary about whether they like the behavior change wheel or whether they like the theoretical domains framework. And it's a personal thing, and you can actually map across them. But the center to the behavior change wheel is this area here, the capability, the combi model. And this largely says that our behaviors are driven by three things: our capability, which may be physical or psychological. So, for example, if there wasn't a ventilation machine available for a patient, that's a physical, you're not physically capable of delivering it. Or if you don't feel confident about delivering this, so that this is not something you've got a lot of confidence about. I don't know the clinical area. Avril talked about one of the benefits being, for example, greater monitoring of oxygen toxicity. But if people aren't aware of that sort of background, they may actually feel uncomfortable about doing this because they don't know when they're going to do harm. Motivation: do people plan to do this? Do they? And there's both a kind of conscious and automatic decision process. So the conscious are the things that we spend our times thinking about, and often we have to do that if we want to start to change our behaviour, to really think about what we're going to do differently. But what we hope is that often these will then become automatic decision processes. So you'll automatically think about a patient with COPD who's acidotic, about is this a patient who's that we should be assessing for NIV? But often you have to do this in a much more reflective way. And sometimes, if you want to change people's behaviours, you need to think about how do we support, if you like, the conscious decision-making process to change their behaviour. How do we support that and hopefully enable it to become an automatic behaviour? And then in the environmental factors, you've got, again, physical and social. Some of the physical here, I put the machine in that one. Justin might say differently, but also one of the things Avril described was, you actually sort of had this separation about Ward 4 was where this could get done, other wards where it wasn't. Presumably the geography of QE means you'd have to sort of think about moving people across, and there may be factors around that. And also, some of the social factors would be those things about whether people in the hospital think this is something that's worthwhile doing. That business case that you had to make, and a business case that was solely largely grounded on this is the right thing to do for our patients, even though it might cost us, and even though probably in our budgets we won't see the benefits because it's going to be avoided readmissions, it's going to be better quality of life for patients to get out there. But a social environment where you also have to change. So there are different models, and again, you could do this in your quality team. Are we comfortable that people are motivated to do this? Are they doing this sort of in a conscious way or an automatic way? Do they have the capabilities or opportunities? But it's just saying, start to think about, or try and use some of these models, which, if you like, just direct you to think about key issues that certainly the behavioural sciences would say are important if we want to change our behaviour. It's worthwhile saying that a number of things that Avril described were actually interventions which were not targeted at the individual, but were targeted at the system to improve opportunity and capability. So that was an area where recognizing that there's a problem with either the standing orders, the physical setting of where ventilation could occur, the number of ventilators, the number of nurses. A lot of the intervention that Avril did was actually about trying to improve both the opportunities and capabilities of staff. Okay, so do a barrier assessment, then select, tailor, and implement interventions. This is sort of thinking about which intervention components could overcome the modifiable barriers and enhance the enablers. One of the issues here is that you'll probably identify many, many more potential barriers than you could possibly ever address. So you need to think about which of the barriers are most crucial. If we don't have the NIV machines, then we're not really going to be able to find or create a lot of sort of ability to deal with that. That seems to be something we have to do. There may even be slightly different ways of dealing with the human resource aspects of that. But which intervention components are kind of, if you like, critical, that if they're not resolved, we're just not going to be able to move things forward. And they're often the kind of the system issues. But then you might get into issues in terms of what would be desirable to do, what's easy to do, and building an intervention based upon that. Again, in your form, what you've got, or in the back of this work package, you've got some representation of what I'm going to describe. When I started working in this area, I would say our interventions were things like educational meetings, audit and feedback, opinion leaders. And if you talk to people who are interested in changing behaviours, they would say they're not necessarily behaviour change techniques, they're ways of delivering behavior change techniques. So in an educational meeting, you could do a lot. You could do didactic information provision. You could do social persuasion. You could do skill building. You could do sort of encouragement around monitoring. And so with the behavioral toolkit is actually probably much richer than often we think about in a quality setting. And this was another piece of work done by, again, Susan Meeke from University College London, where one of the other challenges in health psychology is that there's a profusion of terms for different techniques. And so what she did was get an international group together to say, can we start to agree how many behavior change techniques there are, start to define them, and start to classify them into groups. Again, as a way of helping us think through, what's the toolkit that's available to us. So what they identified was, I think it's about 15 or 17? 16. There you go. 16 groupings of interventions. There are interventions that, for example, focus on scheduled consequences, reward or threat, repetition, substitution. So these are kind of high-level clusterings of interventions. In the paper, then under each of these approaches, you will find that there are a number of individual behavior change techniques, and you can't read that, and I'm not anticipating you will. But if you look under, say, the third area, repetition, substitution, the suggested there are potentially 6 different or 7 different interventions. You can try and substitute behaviors. So often if you're trying to change a behavior, it may be helpful for people to focus on doing a new, substituting a new behavior rather than sort of telling people to stop behaviors because they often want to do something. Habit formation. So actually making this sort of, how do you actually ensure that as a patient with COPD comes in, someone is doing a blood gas at a level where they can look for acidosis, and it just becomes part of the habit and patterns of what we do here. There may be habit reversal if people got into, we'll do blood, we'll do blood gases, and then we'll wait sort of another hour to recheck them before we think about doing, really trying to move it forward. If that's a habit that people got into, then you might want to think about specific issues about how do we break those habits. Graded tasks. Sometimes it's easier to start with, basically unthreatening and simple things before you move into more complex behaviors. So this comes from the idea that if you have a phobia of spiders, maybe I'll say the word spider in your presence the first week. Maybe after 3 weeks, I might show you a picture of a spider. 3 weeks later, I'll say there's a spider outside the door. And eventually we'll show you, we'll bring you a spider into the room, put it in a box over there so you don't have to look at it. But those things are also things that actually we can use to think about changing our behaviors. So again, and you can see that there are kind of definitions. So graded tasks, set an easy task, increase difficulty until the targeted behavior is performed. This doesn't seem as obvious to me how it applied to the example that Avril gave, because it seems to me that we want the complex behavior to be delivered relatively consistently. One of the other things that Susan and colleagues did was not with the 93 techniques, but with the previous version, is they developed something called the behavior change matrix. And so what you have along the top is the theoretical domains framework. It's actually the original version, so there's 11 domains. And down here you have, I think it's about 33 techniques. And they just got a group of psychologists to say, if you want to, say, change skills, column 3, which of these techniques do we think would be potentially useful? And the white bars are where they agreed this would be useful. The cross-hatching were where they agreed it wouldn't be useful. The blacks were where they couldn't agree with each other. And the vertical lines were where they sort of said, we just don't know. And so you could see that if you're let's say we wanted to change a skill, then you might think about, well, our menu for changing skills are specifying a goal or target, self-monitoring, establishing a contract, graded task, increasing skills, stress management, planning and implementation, homework, personal experiments, and perform behavior in different settings. Now, my guess is, certainly when I kind of came across this, I wouldn't have thought about the majority of these. And a number of these things also may not be applicable within a clinical setting to try to change health behaviors. But it gives us a richer set of tools. For example, one of the things that I didn't believe would work until I saw randomized controls trials showing it did work was if you do educational sessions with GPs and you get them to sign a commitment to change based upon what I've learned today, I'm going to go back and change my practice, they change their practice, or they're more likely to. And I have to confess, when that was first described to me, I was thinking, if I was a GP, I'd be thinking, bloody hell, what on earth is this? Do you think I'm an idiot? But there's a lot of evidence from psychology about just getting people to move from, and Justin will talk about this, from a kind of general, I'll do something, to some form of commitment or some form of plan means they're more likely to change their behaviors. These are fundamental attributes about how human beings behave. And so if we can use these when we're thinking about trying to change basically our behaviors, our behaviors of colleagues and patients, we may be more successful. So it gives you hopefully a richer toolkit to look at. One of the other things is that we've talked so far about the theory of mediators and behavior change techniques. We also need to think about, well, how could the interventions be delivered? So if we did want to do something like monitoring or self-monitoring, there may be different ways in which we would deliver that. So monitoring, for example, it may be you do an audit and then you provide feedback within either a group setting or an individual setting. Self-monitoring could be something which actually you get a clinician to monitor what they're doing and then think about what they're doing, and they could either use that as an internal process or they could also discuss that with the team that they're working within. So one example, I was a GP trainee in the northeast of England. I was working in Gosforth with a GP called John Charlwood, who's long retired, was a wonderful man. We did an audit of referrals in his practice, and he was shocked that he had the highest ENT referral rate. And so he actually did some self-monitoring. And what he found was, one of the explanations for that is that he was a senior partner and all his patients had got older with him. So he was seeing all of the more elderly patients who had hearing problems. Jill Miller, who was the only female partner at the time, had the largest kind of referrals. But she was seeing probably 10 times more women than anyone else, and so still referring a lot less. But you could have self-monitoring, or if you wanted to change your behavior, you could basically try and change it and then monitor what was going on. We wanted to, again, in an Australian study, change GPs' low back pain x-rays. And you could either get people to monitor what happens for the next 10 x-rays you order. Did it change anything that you did? And if you can get them to decide to change, okay, monitor the next 10 after that. Was there any problem with that? Or maybe the next 100. So it's a way of self-learning. So as well as sort of thinking about these techniques, you also need to think about the delivery mechanism. Can we do this in an educational session? Can we do this in some form of structured way? And often if you've got existing activities in a hospital or trust, if you can embed them into there, it makes it a lot easier. So it sounds in Gateshead as though a lot of this was done within the kind of the group review rounds that you did. People are used to that. They've probably got worked out what the rules of the games are, and they'll play with you. So we also need to think about the mode of delivery. And then the final thing would be, it's quite likely the first time we do something, or the first idea is not going to be particularly perfect. And so this is a suggestion about either piloting it in certain settings, or you can also, human factors do what they call usability studies, where you get 5 to 8 people to experience the intervention and just see basically how they pick up on that. Do they identify practical issues that you haven't addressed? Do they say, I still don't understand why I can't tie it to Avril's example, so I apologise. But you still really haven't persuaded me, for example, that I shouldn't be X-raying patients with low back pain in primary care. So we need to build the social persuasion bit a bit further. And so, if you talk to engineers, they would say, we never get it right first time round. Probably never get it perfect. So actually be prepared to sort of test this out in a number of different settings. Again, there are challenges, because I think in Avril's example, this was something where you really did have to switch it on. It wasn't something where you could say, well, we can try it and see, but you could switch it on and then presumably make mid-course directions as you went along if it wasn't quite working, or if you weren't getting that full coverage. Okay, so if we then look at the rest of the cycle, there's kind of monitoring knowledge use, evaluating outcomes, and that's where it sounds like a QE currently is. Avril's given us the kind of first 2 months, which look really interesting. And then the issue is about sustaining knowledge use. There could be a whole range of reasons why, over time, this intervention might lose, or the change might become less effective. It could be you have a turnover in the nursing staff. It could be that some of the machines need servicing and out of order. It could be that during certain times of the year, the flu season, that it becomes a lot more challenging to do this because of the just patient pressures. So again, one of the issues is, and Justin will talk a little bit about this towards the end, can you start to identify under what circumstances there will be challenges in the organisation to deliver what you want, and can you start to plan ahead about how we'll actually work that through. We're not going to, we may talk a little bit about these during the small group, but I'm not going to say much more about this. But again, it does suggest that, I think as Avril was saying, it also suggests that if you want to do this, it has implications for your organisation about what data you have, how easy is it to access, how interpretable it is. Does the data actually match what you're interested in doing, or what you're interested in trying to assess? Because often the data we collect routinely isn't a good match for the kind of the nuanced clinical care that we're trying to deliver. Any kind of immediate questions, or people happy for coffee?
I guess my take on it is the critical choke point is at 9 o'clock, assess barriers to knowledge use. And I think I'm a secondary care physician, so my challenge is most COPD is looked after in primary care. If you look at the mission statements of clinical commissioning groups over the last 3 years, COPD has come on and then disappeared off.
Yeah.
If anybody can show me data showing that that's because we've been so much better at doing COPD, I'll be absolutely delighted, because then I can do another job. So the bottom line is everybody knows we should be doing something. Everybody said we're going to do something, and nothing, I would argue, effective has happened. Because it's on a mission statement, it's now fallen off at least 3 of 6 that used to have it. It suggests that something else has come on. So one of the big barriers to implementation is prioritization. Yeah. And that's the big issue we have here. The only reason you got your NIV is somebody in the organisation said, we have to do this. And that's the thing I really want to learn about, how to get people to, because COPD is one of the top three causes of preventable admissions. How can it have fallen off mission statements when CCGs are about better care at better cost? Mm-hmm. And I really struggle with that choke point. The other choke point is at the bottom of the funnel is having somebody to get time for the data, and I'm really pleased the HSN has got that. But those two parts of the bits I really struggle with. Why are we losing the plot with COPD?
They're really good comments. I don't have any sort of... I think they're things that we should take into the group, because I think, again, Avril was talking about the kind of persuasion in the trust, and presumably there were... the trust had a number of local champions that would be prepared to take that on and actually continue to deliver on that. There's also, there's aspects of this where, I don't know if I said this last time, I think if we're trying to improve quality of care, we need kind of, at least 3 different kind of sets of skills. One is internal knowledge, and that will be about internal processes, but also internal politics. And I think, often the very successful quality teams have a good sense about the local politics and who do you have to persuade and how do you get them on board to do stuff. And there are some techniques about that, but it's also to some extent an art, and about relationships and sort of constant sort of being helpful and making people recognize who you are, and that you're there to try and help them and you're interested in what they're trying to do. So I think Avril's comments about making this a clinical issue rather than necessarily a sort of an obvious financial issue, partly because I think is probably hard ask, but that might have helped with some of the clinical colleagues. So I think some of this so there's internal knowledge. I think what we're describing here is external knowledge about how to change behaviours, what are some of these behaviour change techniques, and my guess is even now if I sat down with a blank piece of paper I wouldn't come up with 93 ways of changing behaviour. I'd be much more truncated than that. So, we can do that. And then it is actually also about the skills of change management. And again, I think that's something where, good quality teams have a lot of that already. But it's a challenge, and there's always competing priorities. I mean, you can make virtually anything a priority because there's very few things that aren't either affecting a large number of patients if you look at a population level, or significant impacts on quality of life or costs. So I think there are some issues around how do you actually do that, which we probably won't this time talk a lot about. Although I think in the small groups it'd be really good to get into that.